All right, so I'm going to be doing pretty much an obstructive sleep apnea case study. But real quick, I wanted to kind of go over a few things that I learned under the obstructive file. A couple things that I learned was the circadian variations in lung function with OSA patients, and variation in the parasympathetic nervous system, and the neurohormonal changes that we see and in those obstructed patients. Uh, as far as the circadian variations, um, and objective measurements of lung function, both we have asthmatics and healthy people. Um, they have their low peak expiratory flow rates earlier in the morning, between usually 3 and 6 a.m. But asthmatics are much lower, right, indicating that they have really bad, severe bronchospasms. And so there's this like fluctuation in amp from the highest to low uh, peak expiratory flow rate. And so the really what happens is the variability in the peak expiratory flow rate and airway resistance is pretty much we really don't know too much about it, but what it could be is that the body cools down normally during sleep, and the cooling helps with the nocturnal bronchospasms, and then breathing in the warm humidified air can help lower that the worsening that happens at night in the lung function. And even if the core body temp um, is usually kept lower, this means that there's a direct effect of relatively cold air on the airway. And also, some of the symptoms that they'll see at night could be due to like a longer, prolonged exposure to antigens like dust mites, or that kind of like live in our mattresses and blankets and our pillows and stuff like that. Um, um, some of the studies that used physical barriers or chemical strategies to help get rid of those dust mites, but they found that there wasn't really big change in the morning peak expiratory flow rates. Um, there could be other antigens in addition to the dust mites that could be accounted for and that could play a role in the symptoms of asthma. Um, and the variations of the peak expiratory flow rate, there's also a drop in FRC that happens during sleep in both normal patients and with asthmatics. And it's a lot lower when it's in supine position, and sleeping when compared to supine and awake, which tells us that sleep itself is important when it comes to reduction in lung volumes. Um, and also, obviously, a drop in FRC can really influence a lot of airway resistance that occurs in these patients, these asthmatic patients at night. As far as the parasympathetic nervous system, um, there's an increased vagal tone during sleep, which could enhance the bronchoconstriction. There's a diurnal variation in the vagal activity that's been shown in asthmatics with higher vagal activity that happens at night. When given IV atropine to patients, and one of the studies that they did with that asthmatic at night, it helps improve their peak expiratory flow rate from 4 a.m. at 4 a.m. compared to 4 p.m., which meant that there's definitely a correlation between the heart rate and the peak expiratory flow rate, which helped us suggest that there was an increased vagal tone at night. As far as the neurohormonal changes, as far as pulmonary function, parasympathetic nervous system tone, the histamine, which is a bronchoconstrictor, was shown to significantly be higher in the asthmatics during sleep with compared to normal people, and enhanced nighttime airway inflammation in the asthmatic at night, which could provide a stimulus for increased endogenous anti-inflammatory activity, in the form of increased serum cortisol levels. And then there's also blunted adrenal response to corticotrophin, which could play a role in the worsening of these asthmatics. Um, So now to move on to the case studies. Pretty much there is a 61-year-old man who's actually a physician who has type 2 diabetes, and he's had it for about 10 years now. Um, he has GERD, um, or other known as gastroesophageal reflux, and he has that daily and has moderate depression. For about the past 10 years, he's been weighed anywhere from, with a BMI of 31 kilograms per, and he doesn't have any hypertension or increased cholesterol, and there's no known diabetes complication other than those two. He has a low carb diet, and he uses a bicycle for exercise. He does snore and reports that he's really sleepy all the time. He doesn't have any family history of diabetes or sleep apnea. In the past year, he's not been able to get his plasma glucose level to under 200. His hemoglobin has been 7.5 on the past 2 visits, and the patient denies any polyuria or nocturia. He's been in bed for 8 hours per night. His wife doesn't really complain much of snoring, but she's also a heavy sleeper. The bed partner, and as we know, uh, the wife is usually the first one to be complaining about sleep apneas with their husband. And in this case, his wife wasn't, but uh, when he went on a medical mission trip, the other docs that were with him were complaining about his snoring and gasping, so he actually requested a private room to avoid, complaints, and he didn't really tell the diabetes care team about that. So he excessively sleepy. He sleeps 8 hours nightly. Colleagues and family sleep in adjacent rooms have told him that he snores and gasps throughout the night. And some of the research that I've read shows that about 50% of men with type 2 diabetes have sleep apnea. These factors are sufficient to suspect sleep apnea, and we should kind of look into it further. As far as what is sleep apnea, it's a very common disorder that in our society at least, and in fact, there's equal prevalent in the U.S. adult population. According to the NIH, over 20 million people have OSA, and only about 10% have actually been identified. It's a disorder characterized by snoring, partial complete cessation of breathing during sleep, lower blood oxygen levels, severe sleep fragmentation, and excessive daytime sleepiness. It's associated with cardiovascular conditions like hypertension, heart disease, stroke, but the scope of sleep apnea is enormous, and it's really poorly recognized. So during the sleep apnea, the breathing, stops and gets very shallow. The person stops breathing entirely for a few seconds, and it's going to happen 100 times a night. A bed partner may hear the snoring, and then this kind of witnesses the gasp, the coughing sound as the person struggles to resume breathing, but apneas and hypopneas cause sleep arousals. The individual wakes to resume breathing out, but not enough to remember any of the interpretation during sleep. Some arousals simply cause the sleeper to shift into a lighter stage of sleep. In other cases, the arousal reduces the arousal. Sorry, I lost my train of thought actually. It actually reduces the quality of sleep. So OSA can really affect anyone, even kids. And sleep apnea is more common in men, and 50%, like I said before, 50% of the type 2 diabetic men also have OSA. As far as diagnosis and treatment, anyone can really identify it. Usually there's a sleep study that's done, and they do an overnight polysomnography in a sleep lab. First line therapy is CPAP. The airway pressure kind of functions like a splint for the upper airway to prevent apneas from occurring and keep the airway from collapsing. This helps normal breathing to continue during sleep, normal sleep patterns to emerge, sleep to become restorative, and the patient to feel better. Usually it helps immediately. And a success, the treatment is measured by the reduction of respiratory disturbances throughout the night. And, obviously less fatigue, less depression, and they feel better. Um, they'll also stop snoring and less apnea events. It's been demonstrated to drop blood pressure and glucose levels within 30 days, actually. So, as far as this case goes, patients with chronic snoring or untreated sleep apnea are obviously at higher risk for cardiovascular disease or stroke. Most of these patients have a higher BMI and as well as low activities levels and hypertension. And it's also possible for patients with normal BMIs and sleep hypertension to have snoring and sleep apnea. Sleep apnea can be associated with, weight gain. Tiredness can cause people to eat for stimulation and skip exercise. And this can, result obviously in obesity, which can worsen the sleep apnea and lead to progression and severity of both conditions. The sleep deprivation for any cause increases glucose, blood pressure, triglycerides, causes higher evening cortisol levels, reduces serum leptin secretion, increases inflammatory cytokines. Treating sleep deprivation rapidly reverses these metabolic abnormalities, and the reasons for this are complex, but it's going to help increase the sympathetic nervous system activity and adrenal cortisol and catecholamine output. JB's fatigue and sleepiness eventually, or the physician, right? His fatigue and sleepiness led him to refer himself to a sleep lab in August of 2005. But because he's a physician, he felt certain he had sleep apnea by the time he contacted his friend at the sleep lab. And the most patients are referred to a sleep lab or sleep specialist by their physician. So it is common for patients to complete a Berlin questionnaire, which is it's pretty much 10 questions certified by the American College of Physicians. The questions kind of focus on your BMI, snoring, sleepiness, and blood pressure. And his results pretty much show that a borderline acceptable BMI, severe snoring, severe daytime sleepiness, and acceptable blood pressure, which can mean high risk in two categories for the questionnaire, suggesting a strong likelihood of sleep apnea. He underwent a sleep study, and because of severity of sleep apnea, a split night protocol was initiated. So pretty much what that means is the first part of the sleep study was so severe that the patient was placed on CPAP therapy for the second portion of the night. An apnea or AHI or apnea hypopnea index of 51 was reported for his results during that diagnostic portion of the study, which means that he had severe obstructive sleep apnea. And obviously, an apnea is pretty much a no airflow for over 10 seconds, and a hypopnea is greater than 30% reduction in airflow for greater than 10 seconds. And O2 sats will drop about 4 to 5%. As far as how to treat it, an AHI over 15. But some patients are able to reduce their AHI with just weight loss. A few patients are able to maintain this type of weight loss, but CPAP therapy is obviously first line. I know at John Muir we use pressures between 4 to 20 centimeters of water. We just call it like a flex or biflex, even a C flex. And then JB, he actually needed a pressure of 8 centimeters of water. And the pressure needed to help with about 95% of the apneic events through the night, which determines this therapeutic pressure. And so he went home with a prescription for CPAP, and a local home care dealer delivered his therapy that day, and he slept with CPAP pretty much ever since. He says he's feeling great, and the family members have noticed a huge difference in his energy levels. And some of the studies show that CPAP can improve insulin responsiveness without a significant change in obesity. And this happened in his case. Although his weight and diet have not really changed, his glucose levels have improved a lot and are now consistently under 150. His A1C was 6.5% 9 months after the CPAP, and his meds have been lowered. So this kind of shows that physicians and even RTs or nurses really need to help assess with sleep profiles among these diabetic patients. This patient kind of estimates that he had sleep apnea for 10 years before getting to a sleep lab, right? So that's obviously a huge issue. Diabetes and sleep apnea are actually frequently coexist because obesity is a risk factor to both, and little is done to assess for diabetes and sleep labs or screen for sleep apnea and diabetes programs. So, I mean, I think now we should start looking more towards that. We obviously have all these fast food restaurants, and I feel like a vast majority of our population is considered obese in America. So I think we need to really start looking at these kinds of interventions. Anyway, these are my references, and thank you for listening.